Welcome to Resilience Radio. This is Irvin Eisenberg. I'm the host of the show and owner of Resilience Occupational Therapy. As always on this show, none of the opinions expressed by guests are meant to be medically diagnostic or prescriptive in any way. Everyone has their own healthcare needs, and there's no one-size-fits-all approach. So I like to feature a variety of different approaches. So I'm particularly excited today to have Vanessa Blackstone, who is a social worker who specializes in pain. And on other episodes, we've talked about pain from an occupational therapy standpoint. And if you've been listening to the show, you have recently heard from Adrienne Lowe, PhD and PT, who specializes in pain. But I was excited to have this conversation regarding from more of the mental health standpoint in discussing pain. Well, it's great to have you on today.
Happy to be here.
Can you tell me a little bit about the clinic you work at and what the approach is?
Absolutely. So we are the Pain Psychology Center, and we're a group of about 45 providers, ranging from licensed therapists, both LMFTs and LCSWs. I think the acronyms are different in each state, so you might have to look it up and how it applies to your state. And then we also have a psychologist. We have a handful of associates, people pursuing their licensure. And then we also have a handful of coaches. So there's about 45 of us, and we specialize in the treatment of chronic pain, otherwise known as neuroplastic pain and arm, where it's pain with no structural cause. And so what we're also specializing in, what was created in our practice, is pain reprocessing therapy. And so essentially, what we do is apply the tools of pain reprocessing therapy to symptoms that have had no effect from other treatments, particularly from symptoms that we just feel kind of stuck with. The client feels stuck, the provider feels stuck, and even if we're having imaging exam results that show us some sort of abnormality in the body, what we're doing with pain reprocessing therapy is seeing if this modality can allow us to shift our perspective and our relationship with pain in our body in order to allow us to feel safer and reduce the pain fear cycle. Along with that, we specialize in a variety of other focuses and modalities. It's not always just about pain. Sometimes pain has a comorbidity of generalized anxiety, depression, OCD or OCPD, which is obsessive compulsive personality disorder. It can also have a comorbidity with substance use, eating disorders, and a variety of other barriers that we see. So all of our providers, there are therapists that specialize in those other barriers. Our coaches specialize primarily in pain reprocessing therapy. But our therapists also provide other perspectives as well. EMDR, ISTDP, IFS, hypnotherapy, and I'm sure I'm missing something. Some more from there.
Oh, so there's a lot I'd love to unpack there, but before we got into that, I'd love to hear what brought you into this particular field of social work.
Yeah. So I had pursued my bachelor's in psychology, but long before that, I have a long history of my own chronic pain. I've had pain symptoms since I was 11, and they've grown to different things and exacerbated over time. But for me, grad school was probably the worst. I was at USC pursuing my MSW, my Master's of Social Work, and I probably was dealing with about 6 different pain symptoms at that time, and it all kind of hit me when I was at graduation during grad school, and all I wanted to do was just kind of get through the day. I really wasn't feeling celebratory or excited. I was in a lot of pain during the ceremony and during celebration. I had really bad IBS symptoms while waiting in line with everyone to hurry up and get your diploma. And then my migraine was kicking in really intensely, and I get really bad vertigo and nausea. And then I also break out in hives when I start to get really stressed out. And when my head starts hurting, my neck starts hurting, and all of it was happening at the same time. And I was just wanting to get this graduation over with so that I could go on to the next thing. And for me, the next thing was my PhD. and I was going into a PhD for mindfulness-based relapse prevention, which is a cousin of mindfulness-based stress reduction. They're really interesting areas. If you want to go down a rabbit hole and research it, you certainly can. But MBRP is actually quite similar to pain reprocessing therapy. It's just geared towards substance use and recovery, but the practices and the perspectives and the work are the same. I think that's why I found PRT so fascinating. But I was getting through graduation, and after graduation was done, I just vented to a mentor of mine, who's my grandfather, and I just told him, like, I'm miserable, and I just feel like if I can get through this summer and start the PhD program, I'll be fine. And he said, I don't think that you should start a PhD that way. He said, I think that you should take a break and reset, and you can go back later. And he was right, and I did, but I was devastated. I was so upset that I felt like I hadn't done enough. I'm very type A, so I can relate a lot to my clients who have this type A personality that often sets them up to have the symptoms of neuroplastic pain. But I'm very type A, and so my grandfather said that, and I decided to defer. It was not an easy decision, and I thought maybe it would come with some symptom reduction. It didn't. I actually felt like 10 times worse because I'd never slowed down before. I've always gone a million miles a minute. But nonetheless, in that process, I heard from another mentor of mine who's a previous supervisor. And though she wanted me to find my career path, she also, I think, really wanted to help me feel better physically. And she suggested pain reprocessing therapy. I think initially she suggested it as treatment, but I was like, oh, a job. And so I took the opportunity to reach out to the Main Psychology Center, which at that time there was only about 10 people here. And so I reached out, interviewed, got the job, and it wasn't until I started really learning about the modality where I started realizing it applies to me. So I was working on this both personally and professionally kind of at the same time when I first started. And like I said, when I first started, there was 10, and now there's 45 people.
So the initial hook was personal curiosity, was professional curiosity more than personal application.
Oh, 100%. At first,
so you were sort of distancing yourself. Yeah. So you're sort of distancing yourself from the work, even though it was actually probably recommended to you because it was a therapy that you would benefit from.
Yes, absolutely. And sometimes I joke with clients when I can, when it feels appropriate, and they'll come in and they'll say, like, I'm sure this sounds so crazy to you. I'm like, no, you as a person are really unique, but your story is not. I can relate to it. I've heard it a million times. You are so unique, but your story isn't. What got you here isn't. So it's very relatable how all of us get here into pain reprocessing therapy.
Just yesterday was working on a client, and it was body work, but they were like, I'm so tight in here. Is that particularly tight? And I was like, I said, you as an individual are a very unique human being in this particular personality of a character. I said, but this particular attention pattern is not.
Sorry.
You don't have to own this one for your individuality. Yeah, we can let this one go.
Absolutely. Absolutely.
So we haven't really delved into the sort of different types of pain and what neuroplastic pain means. And I'm trying to decide let's get into that. What is neuroplastic pain, and how do you know you have it?
Yeah. So neuroplastic pain involves essentially pain with no structural cause. It's like a false signal from your brain, right? Because all pain is a signal from your brain that your brain knows to keep you alive and to keep you safe. And when it detects that you could be doing something that could be hurting you, it's going to send you a signal. Sometimes that signal is coming from an actual injury, and we experience the injury, we recover, we heal, and we move forward. But some people don't. Or sometimes that's coming from something, for some reason, that just fired up during a stressful time. It can be almost like a delayed trauma reaction, adverse childhood experiences that suddenly become really impactful later in life. Or it can come from a stressful time like losing a job, moving or a change in a relationship or anything else that adds stress to our life. Wherever it's coming from, neuroplastic pain can arrive from many different destinations, from many different stations, and into this destination of neuroplasticity. And I think sometimes people get really confused because they feel like with neuroplasticity, we're saying that there's no structural damage in your body or your pain's not real. But the reality is that we all have normal abnormalities. I'm sure, like you're describing, you see it all the time. All of our bodies are all jacked up, and they're going to be as long as we age. And we want to keep aging. So our bodies are going to go through change. And sometimes if somebody is having a pain sensation and they go to a physician that doesn't necessarily know of neuroplasticity or a mind-body connection, what will happen is they will look at their imaging exam results. They'll see things that are normal abnormalities within their body or signs of past injury, and relate that imaging exam result to the symptoms that they're reporting. And then there is the reinforcement that there's something wrong with our body. However, what we are trying to describe in the psychoeducation piece of pain reprocessing therapy is understanding the research behind imaging exam results and how they explain what is or isn't going on in our body. We teach our clients about the physician's perspective, those that specialize in mind-body connection, of normal abnormalities, and talk to our clients about how to take the information that they have received to get to a resolution of neuroplasticity. It's all worked into the modality, and so that's how we often prescribe or describe the symptoms of neuroplasticity to clients and how they got here. And I also want to highlight a point of like people saying, "Are you saying that my pain is in my head or it's not real?" It's absolutely real. Your pain is really, really happening. Why you're getting the signal and why it's as intense as it is what we're questioning to see if we can change that.
And I like to remind people that all pain is all in our head. That's where
Right.
the pain experience resides. This
Totally.
Descartesian model of there is real pain and pain that's in your head is really throwing us off to this day.
Yeah, absolutely. I love that you said that because isn't it, it always perplexes me. I'll have a client say, well, what my doctor said, or somebody said it's all in my head. And I'm like, but it is. They're saying it in a way where it's like you're making it up or something. Like, no, logically, it is all in your head. So I'm like, they're not wrong, but they're saying it in a way that's invalidating.
So when someone comes to me with pain, unless they referred to somebody who and already sort of get that they need some of the pain neuroscience education, which is sort of the Adrian Lowe model that I've been using, they usually are coming in with I've got a shoulder pain, I have what I believe is a structural problem, and I address that, and alongside that ease them into this idea of neuroplasticity and the fact that the degree of pain or the fact that they have chronic pain is something that can be worked with beyond their structural problem. And I need to ease people into that. It seems like if you're going to a social worker for pain, there's a bigger bar to entry, that they need to have bought into the idea that there's a psychological component and a central nervous system component to their pain. Do you feel like people are sometimes resistant to the therapy, or how are they often coming in?
Well, you'd be surprised. You would think that when people reach out that they'd be like bought in and ready. And usually, sometimes I feel like people are reaching out to see how far they can push this to prove that it's not neuroplastic. And a lot of the times our job is to help them with that buy-in. That is, when I first started, there wasn't any, well, not any, but there wasn't a lot of information like this. There wasn't a whole lot of like podcast episodes like yours. There was maybe one. It was like Curable, which is a pain recovery app. There wasn't many books outside of like Dr. Sarno's books or like Dr. Howard Schubiner's book. I'm also Dr. David Clark, who's the president of the QBDA. Alan didn't have his book out yet. The research wasn't out yet. When I started, it was kind of fresh. So to be honest, I kind of felt more like a magician then because I felt like people hadn't read a ton of stuff yet. But once it all started coming up more and more and more, I almost feel like people know too much to the point where if it hasn't worked then, they're reaching out for support with like a vengeance because they're like, well, it hasn't worked for me when I've read the work. So what are you going to do differently? And you're like, ah. So it's changed over time.
And it's grading it in. I find that
Yes.
you have people who are like, well, I understand intellectually this pain
Yeah.
process, which goes a long way in and of itself, but I don't see how that applies to my shoulder or my
Right.
arthritic knee.
Totally.
And when they're talking to me as an occupational therapist who's going to put my hands on that knee and manipulate it and give them exercises to do, I'm able to sort of bridge that world of saying, yes, there probably is some structural component that we can work with alongside it. Whereas you, and I don't know the rules and licensure in your state, but I'm imagining are not manipulating your client's knee when they have chronic knee pain. How do you make them feel like that their pain is being heard
Yeah. Yeah, absolutely.
using your tool set?
Yeah, you mentioned something that I just remembered. You talked about the uniqueness, and sometimes I tell clients, I'm like, I don't think that you just have chronic pain. I also think that you have a belief that you're like chronically unique. So you always feel different from everybody because we feel alone and isolated and frustrated, and we get really stuck in that world. Sometimes when I say that, I'll get a nice chuckle from a client, like I do. I'm like, yeah, you're like, I'm chronically unique. It's like, think you're so different from everybody else. And my favorite is when somebody says that I'm probably like your most difficult client. I'm like, no, not in the slightest. But yeah, back to your kind of question here. Remind me what you just asked.
So I feel like I'm able to meet some of the clients' desired. Why they're coming in is often because they want manual therapy from me,
Yeah.
massage because that feels good, and that is a useful tool I offer. But often I want to be having the conversation around pain management, and I'm giving exercises and such. I'm just curious, what is your tool set to be? What are you drawing on to make people feel heard and not resistant to this neuroplasticity?
Yeah, I think that this is what I love about being a therapist and talking about chronic pain is that our whole job is to educate and validate constantly, constantly validating, constantly urging someone to become a better person, better version of themselves, right? And to grow and find their areas in which they want to grow in so that they feel like they're working on something to just be someone that allows them to exist more comfortably in the world. And so I kind of love being a therapist doing this work because our whole job is around validating and ensuring that this person feels safe with us. And if somebody's trying to learn how to feel safe in their bodies, the most important thing is for them to feel safe with the person that's trying to help them feel safe in their bodies. And so our kind of set of knowledge as therapists just really sets us up nicely for integrating this work and for allowing someone to feel safe. And what we do is we start with psychoeducation, of course. A lot of the times, the knowledge of where pain comes from is new for people. And just teaching them the psychoeducation behind chronic pain, behind neuroplasticity, and the brain's capability of sending false signals to the body or sending amplified signals to the body. And then we'll often move into identifying areas in our life that validate more that this is right where we should be. One of those things is identifying our conditioned responses. Conditioned responses are essentially when this happens, this happens. So it's like Eisenberg and classical conditioning, and highlighting for our client that they exist in a lot of conditioned responses in their life. And I often will make a list with them because I want them to see it. I ask my clients, tell me what causes pain. When this happens. What triggers it? What you feel like is a conditioned response. And I will have clients give me a list. Like if I sit down for too long, if I bend down this way, if I stand up too fast, if it's cold, if I get in on the driver's side of my car, but not the passenger side, right? They'll like give me a list of all the things that cause pain. And what I will do is have a conversation of how our conditioned responses their brain has taught them to brace for impact, and their brain is working very well, in fact, too well, because it is so wired to send them those signals during those specific activities because it's just trying to keep them safe. And I'll often talk about our nervous system as a helicopter parent, like just hovering over them when they're trying to play with their friends on the playground. And the moment that they feel like they're about to fall, their parents like, right, that's what their brain does for their body.
Well intentioned, and it's good that we have parents looking out for us.
Exactly.
But when is it too much?
Exactly. I used to be a nanny. I still see him. He's my best friend. I used to be a nanny, and I was with him when he was 6 months old, and he's almost 9 years old. And we had a nanny's worst nightmare where he fell and something really bad happened. And I think like 72 stitches later, he was recovering, and his mom was like, "You have to stop being afraid that he's gonna break. Like, go take him to the playground." And he had this like cast on. And she said, "Go take him to play." And when he kept almost falling, I would like run to him, and he was 3 at the time. And eventually he was at the playground and kept falling, and he really loved using his cast to like knock things over. And he almost fell again at the playground. And I ran up to him, and this 3-year-old turns around and goes, "Don't do that. Go sit down." And I was like, "Okay." Wait, sat down, and I had a little cry, and I was like, I think he's telling me to stop because it's driving him insane and it's making him not have fun. He like ordered me to go sit down. And I told his mom, and his mom said, "Yeah, like he's trying to tell you I'm okay, I'm gonna be okay. Go take care of yourself." And so I use this story to describe it to my clients. I'm like, that's what your brain is doing. Your brain is like the traumatized nanny that's like, "Oh my God, I don't want you to get hurt again." And so it's reacting. But you are trying to say, "I got this. Go sit down, take care of yourself, lean in." And I'll talk more about what that means. But we understand these conditioned responses and that helicopter brain. We understand our avoidant behaviors, as Alan Gordon would call them. I have some clients that like to call them soothing behaviors. And what they are is anything that we do to stop, ignore, fix, power through, soothe the pain. And so all the things that we do that are a part of our daily lives to do just that, right? So I will often make a list of both of those things with my clients to help them feel more seen and validated so that I understand their pain story a little bit better.
So I often get the clients who are, I hurt, but I just need to push through. And there are people who I feel like are oversensitizing the nervous system. They keep in, anytime they feel a little bit better, they decide to go for a run again at full speed instead of like maybe go for a walk first and then a slower run. And then they sort of re-traumatize that, or they're just pushing through in pain because they have to get the work. How do you help people find that balance between when maybe the kid with the broken arm shouldn't be climbing to the very top of the, and then attempting to use the monkey bars when they only have one fully functional hand because of the cast,
Absolutely.
versus when the nanny just needs to sit down?
Yeah, absolutely. Yeah. So this is where the therapy part can come in, right? Or this is where the coaching, right? And trying to understand, why is that a trait that you feel so committed to? Why is that a part of your repertoire of how you deal with life? Oftentimes I will ask my client, who did you learn that from? And what part of your life did you learn to always just get through something? I'm going to say almost 100% of the time, there is an answer. There is someone in our lives that's the way that we did things and we looked up to them. There's someone in our lives that's the way that they did things and we're terrified of them. There's sometimes no one in our lives who did anything remotely like that to show us how to get through things, and we just are incredible and resilient and figured it out and didn't know where to stop. There's some story behind that. And so we have to take the time to understand that first so that we know why that keeps coming up. It's why it's so hard to just slow down and rest and take a break, take care of ourselves, we have to understand that there's a bigger story behind that.
So it seems like there's the helping people process why, if people are over pushing through, if the child is continually injuring themselves and climbing up and keeps doing that and really should have someone slow them down. What's the story? Why are they compelled to try to go across the monkey bars with a cast?
Exactly. Absolutely.
And the flip side is the person, the child who's wrapped in the bubble and is completely like, okay, I'm just going to sit in the stroller and watch all the other kids play because I'm going to have helicopter nanny right here.
Yeah, absolutely.
And it's sort of, how do we find the balance between that? Something I was thinking and for me, I go to more mechanical things because that's what people tend to come to my clinic for. But knees, and there's a very common, I have arthritis in my knee hurts. Do you think it's arthritis? Or my knee hurts, I have arthritis. And I get this, and I say, well, you probably have arthritis in your knee. I'm not going to disagree with your scans. You probably have arthritis in your knee even if you haven't had the scans. I probably have arthritis in my knee or some joint in my body, even though I might not be feeling it. And I like to remind people that even though just because you have the diagnosis doesn't even mean that's why you had the pain. That I'm in my mid-30s, and if I had a full body X-ray, I'm sure there are joints in my body that have arthritis, significant arthritis, that I'm just not aware of. And if suddenly that joint started hurting significantly tomorrow, I might go in and get an X-ray, and they'd say, oh, your shoulder has arthritis in it. That's why it hurts. It's like, but that shoulder had arthritis in it probably for the past 5 years or the past 10 years, and it didn't hurt. So arthritis doesn't have to equal pain.
Right.
So what does that mean, and how do we work around it? And from my clinical standpoint, I'm often trying to get people to realize that, and then I'm also getting them to move their shoulder or move their knee and start building up muscle around it, because if you build up muscle around it and fluidity, you can actually have that tolerance, and a very arthritic knee or hip can actually, in many cases, not be noticeable with the right activities.
Absolutely.
All that said, so the doctor, people can latch onto the diagnosis. The doctor says I have a bone-on-bone arthritis, and that's with the best of intention. If you go looking for the problem in the biomechanical, you're going to find something.
Absolutely.
And so I'm not a doctor, but so I'm in a similar circumstance as you. But when someone has, do you get the, well, you don't understand, I have bone arthritis in my knee. Are you telling me I should do things I shouldn't? And questioning of your medical knowledge and whether it's safe for them to push forward, or where is that rub, and how do you deal with that?
Yeah, that's a common one for us. And what I tell my own clients, and honestly what I reassure in some clinicians, because that can feel so scary to hear as a therapist or as a coach, and being like, well, that's not my area and I don't know how to answer that question. What I will often first go into is that it's not that black and white. I know that we're feeling like, well, if there's nothing wrong, that I should be able to do X, Y, and Z. And like it's not all or nothing, right? It's about listening to your capacity along the way. And it's about knowing when to listen to the need to take a break or to stop if we are worried about something like that, right? And knowing how to rest and reset. I have a colleague that does this. He's an avid surfer, and he was told that he has bone on bone in his shoulder. And so he tells the story where he was out in the water one time and his shoulder was starting to hurt. And he was getting so frustrated with the fact that it was hurting, especially knowing that it doesn't necessarily mean the bone on bone, that that's why he has pain. And so he was kind of starting to like teach it a lesson or power through. And the more that he would do that, the more that he would like wipe out and fall. And he'd get back up and get frustrated and try to do it again. And then he would wipe out again. And he said that he realized that he just needed to pull back, that it didn't have to be that serious. That he didn't have to try to get like the best wave or do his best, that he's out here to have fun and just enjoy himself. and then it's not that serious, and to slow down and what I call rest and reset. Just drop into your body and drop your belly, noticing where the sensation is at. Practicing a little present moment awareness just by following your breath, noticing your environment, and whenever you're ready, get back to it. Maybe this is your sign to take a break. Whatever it may be, your goal is to just pause and listen to yourself and see what you need. Right? And what we need can often be a really hard question for people, and that can be further explored and processed in sessions together. But I think that giving that as a reminder that it's not that black and white, and it's actually about also listening to yourself along the way and knowing when you've hit your capacity and knowing whether or not taking a break means that you're done or that you need to, or that you would like to get back to it. And the way that I describe these structural components of what our body is going through and whether or not it's contributing to our pain is like pain reprocessing therapy is like couples therapy. Something has happened between you and your body. Maybe it feels like it's cheated on you or something, but you don't get to like switch it out for a new partner. It's like you're stuck with it, right? And so what you were doing in pain reprocessing therapy is trying to figure out how to cohabitate, how to coexist together when something has happened in the relationship, right? That's our goal together. And answering that question of when it's bone on bone, which are you saying that I should just do physical activity? Or should I just do the things that I'm not supposed to do? Or push it or power through? We're going, how are you two communicating? Does it feel like you're on the same page? Or are you starting to feel frustrated with each other? If we're starting to feel disconnected and frustrated, that might be our cue to lean in and to rest and reset and see from there if you need to continue forward or take a break.
So one of the things that's making me think of it, I guess, so it's the powering through piece and the when to do too much. And how do you know you've done too much, or how do you know haven't done enough? And it's not what's too much today is not, or isn't, or in this minute might not be what's too much the next minute.
Yeah, absolutely.
And letting people know that you're gonna fail. That's how we know where the boundaries are. You're gonna say, "Oh, I should have pushed myself a little more," or you're gonna say, "Ooh, I pushed myself too much today." And it's the self-reflection on that and it gives you a nuance of knowing what you can do. Something Adrian Lowe talks about is that you got someone like Tiger Woods, and this is sort of an example of neuroplasticity, who can get so good in his neuromuscular firing that he's an amazing golfer, and his mental state and his executive function to be able to do the focus he does is incredible as well. And we have the ability to hone in on a task and get really good at it. Our brain is plastic for a reason, so we can get really good at something. And in some cases, people get really good at having a pain experience.
Absolutely.
And it's like you're really good at pain. Maybe you want to diversify your skill set a little bit on this. You have other things that you're good at too, but let's get good at knowing what the pain means and exploring that nuance of when is that too much, when is that too little. And it can get I could see some people getting obsessive about it, like knowing exactly what it is, but not taking it too seriously, because realizing that there's a large buffer in there before you're actually injuring yourself.
Yeah, absolutely.
And it doesn't mean you should just plow through, because you can injure yourself. Like it's
definitely.
But that doesn't mean you shouldn't play on the playground at all.
Exactly. When I was in that tough couple years in grad school, I had this awful accident, two accidents. My brain was just so preoccupied with school, with my perfectionism of doing it all perfectly and just powering through to get to graduation. I also move like 1,000,000 miles a minute. And so therefore I'm really clumsy. And I don't know if I invented this or if I heard it somewhere else. I don't want to claim it if it's someone else's, but I often say that clumsiness is an example that the brain is somewhere that the body is not. So my brain is in my office and my body is walking down the stairs. And I'll describe that to clients because that can be really scary. They've had all the imaging done, but they still feel like they're having issues with clumsiness and they worry it's underlying neurological barrier. And sometimes I'll describe clumsiness this way. It's an example that the brain is somewhere that the body is not. And when I was in grad school, I was on winter break and I was starting to get sick, but I really wanted to put this desk together in my home. And I started putting it together and I dropped it and it broke all 5 of my toes where my toes meet my foot. And I was in a boot for a while. But then the semester started a month and a half later, and I was walking down the stairs at my practicum and just stressed out beyond belief. And I fell down the stairs and I broke my tailbone. I think back to this now and I'm like, I literally that's the definition of powering through. I did not stop. Nothing else was important except continuing to go. So much so that like taking care of myself and slowing down was like or actually I was going to say it was the last thing on my list, but I don't even think it was on my list. And when I see clients powering through and I hear them trying to just like manhandle their pain and push through, when I hear them feeling like they need to do that with this work, funny enough, it actually kind of like stirs this feeling up in my gut where I'm like, oh, I know that feeling all too well. And so when I hear them going, the main practice within pain reprocessing therapy is somatic tracking. When I hear them going, I'm trying somatic tracking and it's not working, I'm like, that's because you're doing it with the same energy that you do everything else, the same urgency and the same intensity. You're just taking the same energy and applying it to trying to recover, and it's not going to work. And so oftentimes that's my cue to have this conversation with clients of we have to slow like way down, right? So much so where we have to identify in your life where you might be just slamming down the gas pedal and powering through and slowing down even when it's uncomfortable. Because the reality is you're already going to be uncomfortable. Why not learn a skill that's actually going to help you decrease that? And it might be hard in the beginning, but we have to prioritize that.
Well, I think that's a great note for stopping on right now. Thank you so much for coming on the show. It's been great having this cross-professional discussion about pain.
Absolutely. I love it. I got feel being an OT and the fact that you share the work the way that you do, and you're so open to hearing our perspective as therapists and knowing what we do within our modality is so important. Like I said, I started this work when not a whole lot of people were super into hearing from therapists about chronic pain. And so it's just really cool to have these kinds of conversations and know that like treatments are changing and our perceptions are changing. And it's such an important part of us moving forward in the work that we do because people reach out to you for help and getting a bigger perspective out of just what's mechanically wrong with our body, but knowing what can be contributing from our nervous system is just like, it's always mind-blowing to me. It's very exciting to me to have these kinds of conversations. It's special. I love it.
Me too. I often have, and I meant to warn you about this to begin with. I have tried to, if it happens, I like to go, okay, this is a good stopping point on the sort of core of the interview. And if I have lingering questions, sort of save that for bonus material. So I don't want, if you're still at the time, I don't want to send you away yet. I have had other things I wanted to discuss. I just thought that was a nice, I like to see if I can have smaller episodes. And I was like, oh, we're getting to 39 minutes. And that's great. Yeah. We had a lot of rich information. I have a few different notes and questions I had for you, but I guess, is there anything you wish we had talked about or questions you wish I had asked?
No, this is great. Yeah, this is all good.
Okay. I wanted to discuss a little bit, and I don't pretend to be an addiction expert at all, and it seems like you were heading in the direction of that being a PhD and focused on that. Something from clinically I've become aware of is, well, a couple of things around this. One is that, according to Adrian Lowe, 6 minutes of running is the equivalent of 10 milligrams of morphine as far as the amount of pain meds that the brain naturally creates and gives us. And that's a great reason why exercise, if you can do it without further injuring or irritating yourself is a good idea. But it also leads me to think about the opioid addicts, where there is a trend, and I don't want to belittle personal trainers who have this, because there are many personal trainers who used to be opioid addicts. So they replaced one addiction, their opioids, one pain med, with another pain med, their exercise. And one is, for the most part, is both socially and health-wise probably a better addiction, but exercise can be an addiction when people are seeking it for that. And that intensity, as you're sort of saying, like bringing that intensity from one exercise is good, but you do need a rest day, or you're degrading your muscles and you're not actually helping the system overall. And I can see that happening in some clients. So I was just thinking about pain and exercise, pain and addiction, and you being someone who's both studied pain and addiction. I was just curious if you could speak to those overlaps a little more, and maybe the exercise addict component in there, if it's appropriate to your knowledge.
Yeah, absolutely. This is a common, I don't know if I want to say issue or barrier, just common occurrence within the substance use and recovery world, is just kind of rotating one out for another. Specifically because, not to knock on current treatments in any offensive way, in the event that somebody like really relies on them and it really works for them, because everyone applies work differently, and something that will work for one person won't work for another. But in my experience, what I have seen is I have seen certain more rigid treatments for recovery, following certain steps, having to kind of like follow certain rules within a certain timeline of your recovery period, identifying as an addict, and relying on the structure of things to protect you, because it's almost like you can't be trusted. What I've seen is that can foster other kinds of addictions, because the actual sensation behind wanting to use and tending to the sensation in your body, tending to the process of thoughts in a way that is more mindful and present and tolerating of that distress. Unless we practice that, we're not really getting down to what keeps continuing this cycle. And so that's why I loved the work of mindfulness-based relapse prevention so much, because it has a specific practice called urge surfing. Instead of judging yourself for wanting to use, or thinking that it means something is wrong with you or something bad is about to happen, let's go into it. What does it feel like in your body? Let's explore what the sensation of wanting to engage in your usual addictive behavior feels like, and actually lean into it instead of trying to get out of it. And so that perspective can help a lot of the different things that we might use that are just another thing of our addictive behaviors, from exercise to food to. One time I went to an event and I heard a person, it was an event for a recovery center, and I heard a person say, oh, like, sorry, let me go back. We were at this spa thing, and one of the things available to the attendees of the spa day that was being held by this recovery center was to have like a supplement IV bags. It's really popular in LA. I'm not sure if you all do them out there. They're like popular for hangovers.
I've heard of them.
Yeah, they're like really popular here. But they were offering them at this event, and I overheard someone say, like jokingly, this person was saying, "Oh, I used to do heroin, and now I do IV bags," and I was like, while it's so much safer, I don't know, it's the same thing. And my brain was like, oh my gosh, I have to stop thinking, because I started unraveling in my mind about what that means and what could be helpful. But yeah, we see this a lot, where it's like transitioning or shifting out of one addiction for another. Even if it's healthy, it can still be too much of a good thing. And of pain reprocessing therapy, mindfulness-based relapse prevention can still actually be really helpful for that. And I actually see that in my clients. I see that all the time, where I see someone get better with their pain and just like slam the gas pedal into another thing. And sometimes people will feel like when they're recovered from their pain, they're done having our sessions. I like to keep them, if they can, for a little bit longer. I just want to see how they live their life. And I want to be able to integrate this work into other areas of their life, because it's not just about pain.
So you gave a bunch of different things that the clinic offers that aren't specifically this pain work. And I guess at the risk of asking you to play favorites, are there particular other supplemental modalities that people should be considering for working with chronic pain? Like hypnotherapy was one of the ones you mentioned, which sort of caught my eye, which I would like to talk more about at some point. But are there any specific other techniques that play well with what you're doing and play well with chronic pain?
Yeah. My previous clinical supervisor is actually the hypnotherapist that we have here, and she's lovely. So if you want to talk to her, let me know. I'll send her your way. But I think that hypnotherapy or some of the other modalities, I don't know if I necessarily have favorites. I think I'm always going to say, oh, my favorite is pain reprocessing. But I think anything that just allows us to introduce the perspective that other things can be, for example, like heart's work and IFS. Right. Being able to understand like there's this protective part of us coming up in this moment. And that is making it really hard for us to slow down or take care of ourselves. Right. And the hypnotherapy, I think, is so beautiful because it allows us to try to access different parts of the way that we usually operate. Listening to someone who reassures such a sense of safety and being able to like follow their voice into a new place. I think it's so cool. And there's just like different little pockets in each modality that I think are really cool. So I think it's so special as a provider. But I can't remember who said it or what research said it or what, but I just remember hearing something at one point saying that a good therapist is someone who like doesn't know which modality they're using in the given moment. They just have and I think that's what I love about therapy is and the way that I do therapy and the way that many of us at the Pain Psychology Center do is being really comfortable with kind of ebbing and flowing and whatever we are noticing that this person needs and knowing a few different things so that we can actually do that. I think just knowing more allows you to shift in between different modalities that will work at different times for each person. And that's just what I notice in these sessions. That's what I notice in the clinicians when I talk about our clients in group supervision. That's what I notice within my own practice is just being aware that we're using a variety of different things at one point. From hypnotherapy to the urge surfing to pain reprocessing to the kind of traditional CBT and motivational interviewing. We keep that all within our repertoire to just have this like flowing conversation.
So it leads me to wonder about, so some of the pain research, a lot of the systematic reviews on pain research seem to suggest that an interdisciplinary approach is what's most effective. I haven't dug into the specifics on that, but there are programs like Dartmouth has a back pain clinic that has OTs, PTs, nurse practitioners, physicians, social workers, psychologists, all teaching and working together for improving back function. What I'm wondering is what other modalities outside of the mental health do you seek out partnerships with or end up in partnership with?
Yeah, I think that we can really partner with anyone. And I love to partner with just about anyone. Part of my job as the executive director is also to like connect with people such as yourself and to pursue that collaboration so that so that we're all on the same page. I love partnering with any medical provider, PT, OT, other therapists in their specialized field, because it just allows us to like share this information. And especially if we're navigating this with a single client together, almost like a treatment team wrapping around this client, if we both have this perspective that this person is dealing with some sensations that are coming from their nervous system that they might not need, it allows us to treat them in a way that feels more effective. Whereas when we're on different pages, it's much harder. So a lot of the times what we will do as therapists is try to connect with those providers that it might feel like we're on a different page with them, or we'll just try to encourage the client to share the information with their provider, right? And they're welcome to reach out to us in order for us to just share the work that we do. So I think any kind of provider is really somebody that I love to connect with. And I think it just allows us to have this information continue, feel like we're on the same page, a good referral source, right? Because we at the Pain Psychology Center actually work with people out of state and out of country. And so having you in a different region is great for us, because we will have that client in Vermont that needs some sort of like extra support that we can't give. And so it allows us to refer.
Great.
No, thank you so much.
Thank you. I hope you enjoyed this episode of Resilience Radio. If so, you can always share it with a friend and subscribe in the podcatcher of your choice for getting new episodes every week. The music was brought to you by Aaron Marcus with their tune Some Biological Process. You can check the show notes for full credits on that. Thanks for listening. Take care.